Dr. Kshama is professor at the Regional Institute of Ophthalmology, Allahabad. And she's an excellent SICS surgeon. She can do wonderful keratoplasties and also phacoemulsification. And apart from that, she has interest in so much of ocular disorders, surface disorders. So may I request Dr. Kshama to please give her talk. पास करना पड़ेगा.
Good morning, everyone. First of all, I would like to thank APAO and AIOS for giving me this opportunity, as well as I'm very thankful to Professor Kamaljeet Singh sir to make me a part of this useful instruction course. I would be giving my talk on SICS with Pterygium.
Hello.
According to a recent study in South India, at least 1/10 of OPD patients have pterygium in at least one eye, and nearly half of them have coexistent cataract. UV radiation is an important predisposing factor for both these conditions. So, should we deal with them simultaneously? The magnitude of problem increases as we move towards south. It is more towards the equatorial regions. The concern with pterygium is mainly about the pterygium-induced astigmatism, which affects IOL power apart from cosmesis. Studies have demonstrated that even a grade 2 pterygium may induce about 3 diopter of with the rule astigmatism. Excision of pterygium, it induces changes in both the meridia and both the corneal surfaces. The persons who are predisposed to these coexisting conditions, they are mainly from the lower socioeconomic strata who choose to avoid spectacles for various reasons, and unattended pterygium during cataract surgery increases the postoperative refractive errors, rendering the patient optically blind. So, this pterygium associated astigmatism is some of pre-existing astigmatism as well as pterygium induced astigmatism, and both of them are independent variates. Patients of more than 50 years usually have against the rule astigmatism, as pterygium induces with the rule astigmatism. The pterygium induced astigmatism will depend upon grading, and the grading of pterygium has been variably described. One given by tan depends upon horizontal length. The pterygium surface area also decides the amount of astigmatism, and its vascularity was taken into consideration by Sang's classification. Refraction is very difficult in these cases when they are coexistence, and in addition, pterygium induces hemiastigmatism, making the calculation as well as the acceptance of cylinder poor in these patients. Keratometry detects astigmatism only in central 3 mm of cornea. Topography is the best tool for this purpose because it gives central as well as peripheral astigmatism, but in large pterygium it is neither feasible nor required. Pterygium-induced astigmatism is reversible for the most of part. Repeat keratometry after 4 and 6 weeks is done to look for stability of the cornea. Period required for stabilization may vary in different patients and in different grades of pterygium. Change in corneal astigmatism is positively correlated with preoperative grade of pterygium as well as the preoperative astigmatic value. More steepening is detected when bare sclera is performed, whereas mode of graft fixation has no correlation in change. Sequential surgeries have proven with time to provide better outcomes than simultaneous surgeries, and same is true for cataract and pterygium. But there are some patients who should be taken for simultaneous surgeries. There is no need to go for sequential. Like if you have a very small pterygium or lower or absent astigmatism, the keratometry shows regular Myers and regular central corneal curvature on topography. Now this is a small video showing simultaneous surgery. In this we first remove the pterygium. We make an incision, make the subconjunctival dissection, and hold this pterygium tissue and excise it as medially as we can so as to remove all this growth which is underneath the conjunctiva, because this is responsible for most of the poor cosmesis regrowth and everything. Then we avulse the pterygium, make the sclera bare at that side. After harvesting the graft, we can keep it in bowl and proceed with the SICS surgery in a routine way. Once we complete with the SICS surgery, then we take the graft and fix it either with glue, suture, electrocoaptation, whatever is your preferred mode, and close the case. The graft harvesting, some people have suggested it from the pterygium tissue itself, but somehow cosmetically it is unacceptable. So if you have any issues with harvesting the graft, amniotic membrane is a good option. Regarding the position of tunnel, the superior tunnel negates visceral astigmatism to some extent. For double-headed pterygium, you don't have an option, you have to go superiorly. In superior conjunctival scarring, as well as in less than 1 diopter of visceral astigmatism, temporal incision has to be performed, and you have to look for scleral thinning due to previous surgeries. The incision should be watertight, and you should have low threshold for suturing, and antimetabolites have to be avoided. Regarding the IOL power calculation, we reduce the IOL power by 0.5 diopter in grade 2 and by 1 diopter in grade 3 pterygium. There are certain regression formulas which are available, but it depends upon data from other eyes, so I consider them less reliable. Astigmatism management, if you are doing a simultaneous surgery, then we only plan for incision on the steep axis. Any other things are avoided. And in sequential surgery, the management of astigmatism is just as previously described by Dr. Pranav. Now, this is one of the cases. It was TANS grade 3 and SICS grade 2. Prior to pterygium surgery, the vertical astigmatism was 43.75 and the horizontal was 40.25. So we went ahead, did a conjunctival autograft with electrocoaptation. Corneal topography prior to cataract surgery revealed that the astigmatism, the vertical keratometry became flatter by 0.75 diopter, whereas horizontal one steepened by 4.25 diopter. So there are change in both the meridians. We went ahead and did this is the topography after cataract surgery, which was performed with the incision on the steep axis, and you can see how regular the cornea has become. The vertical astigmatism is now 43.5 and the horizontal is 44. So in conclusion, I would like to say that the sequential surgery is better than simultaneous surgery as it prevents post-operative surprises. If simultaneous surgery is to be done in candidates not fit in the criteria, then please reduce the IL power. If it is grade 2, then 0.5. If it is grade 3, then 1 diopter has to be reduced. And please do not attempt for astigmatism management in simultaneous surgery. Thank you.
Thank you, Dr. Kshama. It's a wonderful lecture. And in pterygium, we all know that if you do simultaneous surgery, at times it becomes difficult to get the exact IOL power calculation. So when the cataract and pterygium both coexist together, usually the best option would be to first do pterygium and wait for 6 months and then do the surgery. In smaller pterygiums, you can do simultaneous surgery. Although in Indian subjects, it's very difficult to explain to them that you come after 6 months and then we will do cataract surgery.
I think, I'm sorry,
yes.
6 weeks should suffice.
Some say 6 weeks, but these 6 months is the ideal time for getting the. Actually, I also presented this.
Okay, sir.
2 दिन पहले ही तो थोड़ा knowledge हमारा.
Okay, sir.
तो 6 weeks हम भी
नहीं
बढ़ाया था.
Yes, sir. Yes.
So 6 weeks और. And what I say is that it's 6 months only. हर चीज़ में हमारे यहाँ पैरालिटिक स्क्विंट हो जाए तो 6 महीना, सप्ली लग जाए तो 6 महीना. Everything 6 months. So this way you can remember. Thank you so much, Dr.
Thank you, sir.